Today we'll have two presentations, one from Dr. Desloges and one from Dr. Nawaf.
Morning, everyone. I'd like to thank Dr. Kellner for having me today. Today we're going to be talking about hypospadias. During our third year, as y'all know, we start to do significantly more. We do 4 months of pediatrics, and this was a surgery that whenever we booked it, it was a really great experience, both from a surgical aspect and also from a teaching aspect. So that's what I'd like to talk about today. So let's start with a clinical scenario. This is a common clinical scenario that we as residents get. We get a page for a newborn NICU baby, and the consult is for ambiguous genitalia. Many times it's a day of life one baby transferred from an outside hospital for concerns for ambiguous genitalia. From our standpoint, they're found to have severe hypospadias, but of course we do a workup, and many times there's no prenatal imaging or karyotype available. There's an unremarkable maternal past medical history, and the baby's just in the NICU due to prematurity. So clinical questions that we ask, we want to know if there's any additional labs needed, if there's any additional imaging studies needed at this time, the timing of the surgical repair, use of hormones prior to surgery, and the type of surgical repair. So these are all questions that we'll answer throughout our talk. So typically this is sometimes what we see, as you can tell. This is a severe hypospadias. You see a bifid scrotum, penoscrotal transition, and a severe perineal hypospadias. So as you can tell, for people I don't deal with this very often, there can be lots of confusion that they want to make sure they're not missing something more significant. So you always want to do a good local exam. This goes more into your surgical planning. Specifically, you really want to look at the urethral plate. You want to look at the shape of the scrotum, but you really want to make sure that they don't have any other associated anomalies. You want to palpate for the testicles, make sure they don't have hernias, persistent Müllerian structures, and then you want to rule out urogenital tract anomalies such as UPJ, BUR, or renal agenesis. So just briefly, we're not going to get into intersex, and we're just going to briefly touch base on things to rule out. But is intersex evaluation needed on every hypospadias? So for isolated anterior and middle hypospadias, it's not indicated. For any degree of hypospadias plus cryptorachidism, it is indicated. For hypospadias with development delay, dysmorphic facies, anorectal scrotal malformations, it is indicated. It's controversial with posterior hypospadias regardless of gonadal position or palpability. So just briefly, we get ultrasound, histology, chromosomal, and biochemical and molecular testing. The initial first-line testing includes karyotyping with SRY detection, imaging via ultrasound, 17-hydroxyprogesterone, testosterone, gonadotropins, anti-Müllerian hormone, as well as electrolytes. So just to show you, this is a XX girl with DSD who has congenital adrenal hyperplasia. As you can tell from our severe hypospadias, that's someone that doesn't see this often. It can definitely mimic severe hypospadias. This is a before and after repair picture. But one of the key points to remember, and this is on our in-services, all will have elevated 17-hydroxyprogesterone. So getting back to hypospadia, so it's believed to result from arrested penile development, leaving a proximal urethral meatus. It can be defined as hypoplasia of the tissues forming the ventral aspect of the penis beyond the division of the corpus spongiosum. So hypo means under, spadon means rent or fissure. They've been describing this ever since 2nd century AD. Galen was the first physician to find the term. And then you had these guys in Greece who were describing and classifying the treatment. They described partial resection of glans penis to locate the orifice more centrally. So people have been working on this for a very long time. In the 15th century, we have there was evidence that there was a mitzvah for the treatment of meatal stenosis and hypospadias. This is a guy from the Ottoman period. And then in the Renaissance period, we started to see a more modern evolution of hypospadias treatment. In Portugal, in the 16th century, they described treating a 2-year-old boy with penoscrotal hypospadias. And then fast forward to the 1860s, Boisson suggested a ventral transverse incision to straighten the penile shaft. And then in 1869, Van Hook was the first surgeon to use vascularized island flaps for hypospadias surgery. And then in 1897 was first to use a free graft to create a urethra. When we get into modern hypospadias surgeries in 1971, we started to see a tubularized horizontal interperputial flap to form the neourethra, and then duct it further to this technique with the transverse perputial island flap in 1980. In 1984, we saw a double-faced perputial flap, and in 1994, Dr. Snodgrass used the tubularized incised plate urethroplasty, something that's still very common these days. So there's three major components to hypospadias. So abnormal ventral opening of the urethral meatus, abnormal ventral curvature of the penis, as well as abnormal distribution of foreskin with a dorsal hood. You can have many other findings, such as a downward glance tilt, scrotal encroachment to the penile shaft, penoscrotal transposition, and then of course we talked about the associated conditions of cryptorchidism, bifid scrotum, inguinal hernia, and renal tract malformations. So getting back to embryological, the genital tubercle fuses in the midline, and then you have the mesodermal folds create the urethral and genital folds and coalesce in the midline as the phallus elongates. The distal glands channel tunnels to proximal urethra as solid core and then undergoes canalization. So the prepuce forms as a ridge of the skin from the corona. So hypospadias is essentially failure of the ventral aspect to form with a dorsal hood. And then the chordee forms with a differential growth between normally developed dorsal tissue and underdeveloped ventral corporal tissue. And you see fibrous tissue distal to the hypospadic meatus. It's present in approximately 1 in 300 live male births. There are some genetic components. 8% of patients have father with hypospadias and 14% of the patients have a male sibling with hypospadias. It's more common in Caucasians, and there's a higher incidence, about 8.5 times in monozygotic twins. As you can see from the classification, they started classifying these back in 1938 with first, second, and third degree, and then it progresses throughout the 2004 classification of glandular, distal, and proximal. This is just showing the areas that we can actually see hypospadias. And on this illustration, it gets more into the types that we see. So anterior hypospadias in about 50% of the cases, middle in 30%, and then the posterior in about 20% of cases. So there's essentially 4 types of chordee. So you have type 1, which starts with skin tethering all the way to type 4, which is congenital short urethra. The degree of chordee a lot of times can dictate the type of surgery that you're going to perform, and then and it can also dictate the cosmetic outcome. It's also quantified into normal to no curvature, which is up to 15 degrees, and then mild to moderate to severe, which is greater than 80 degrees. So the ideal age for genital surgery is between 6 to 12 months of age. And the goals of the surgery is normal micturition while standing, normal appearance, then normal sexual function. One thing that was debated in the literature is that, do we give hormones to these patients? Do we give them testosterone prior to surgery? And there was a meta-analysis published in the Journal of Urology in 2013, and they included 11 studies out of 288 into the systematic review, and it essentially said that there were no persistent side effects with the preoperative hormonal stimulation use. It also said that there was really no benefit to using it. However, with a microphallus, which is defined as a penile length below 1/3 of the percentile for age, it's thought that testosterone therapy may stimulate penile growth, and you administer it prior to correction. Recommended starting dose is 25 to 50 milligrams of testosterone given IM Q1 times 3 weeks prior to surgery. Briefly getting into the blood supply. So penile blood supply, the skin has a different blood supply than the actual corporal bodies. The penile skin blood supply is mostly from branches from the superficial external pudendal vessels. And then the corporal blood supply is from branches of the internal pudendal artery. And then the scrotal blood supply, the external pudendal supplies anterior aspect of the scrotum, and the internal supplies the posterior aspect. So for the chordate release and the orthoplasty, the most common are described here, and then these are less common. These are much more invasive and not commonly used to this day. For distal hypospadias, these are the most common procedures that are used today. Kind of starting from the most simple to perform are the urethrometoplasty, where a longitudinal incision is closed transversely, which is also similar to the magpie developed by Dr. Duckett. Essentially, you can see a vertical incision, and then you close it transversely to essentially advance the meatus to a more central location. Down to the tuberalized incised plate, where we're essentially taking our urethra, we're making a shallow groove in the middle, and then we're rolling the plate to create a neourethra. Here they're adding extra interperputial or dartos skin to create a more buttressing appearance, as you can tell at the end. You have a cosmetic outcome, catheters left in place. So for mid-shaft hypospadias, vascular flaps are considered superior to free skin grafts. On-like procedures are associated with a decreased rate of long-term complications, such as fistula and diverticulum formation, compared with tuberalized pedicle flaps and grafts. In an onlay flap, you preserve the urethral plate. It serves as a backbone for repair, thus allowing for a more uniform lumen. And in cases of severe chordee with an atretic or underdeveloped plate, resection of the tethering tissue may be necessary. Here's an onlay island flap that shows that we're preserving the urethral plate, swinging it over, and then we're suturing it in place. For the Duckett tube, for a transverse perputial island flap repair, it employs perputial skin for formation of tuberalized neourethra transferred to the ventrum for hypospadias repair as separate components of the repair. You're essentially taking the inner prepuce, keeping on the vascular pedicle for the neourethra, and you're transferring it to the longitudinal split outer prepuce skin cover. So this is a more mid-shaft hypospadias. This is our Duckett tube that's brought over, and it's rolled into a neourethra, and then we're tunneling it up, and then we're wrapping the skin around for shaft skin coverage. So proximal hypospadias, they're associated with the highest percentage of complications, including fistula, stricture diverticula, and persistent chordee. The Koyanagi repair essentially describes one of the ways that we do it. So as you can tell, it's a very proximal hypospadias. You're making circumferential incisions to the corona, and then you're essentially incising proximal to the meatus. We're bringing the dorsal midline together, and then we're making the all right, here we go. So we're making the urethral plate with a running subcuticular, and then we're tuberalizing the neourethra, and then bringing around Byers flaps for skin coverage. So a lot of times we go back and forth between one-stage versus two-stage repairs for hypospadias. These are mostly reserved for perineal hypospadias, small penis, and severe curvature, essentially because a lot of times these repairs are just much more in depth. So usually for the first stage, you do an orthoplasty. Second page is a neourethra formation. There's plenty of good options for first stage repairs. So most of the time, this is kind of left to surgeon preference as well as severity of the hypospadias. So here we're looking at a penoscrotal hypospadias. They had to divide the urethral plate, and then they're essentially making a midline incision, and then they're swinging skin coverage over to create a new urethral plate. They're leaving the meatus intact. And then 6 months later, after it's healed, then we're starting the Thiersch tubularization, and we're wrapping it up to create the new urethra. Another two-stage repair involves you create a neourethral plate by collecting the glands and releasing the chordee. This is, again, resects the urethral plate, and then you do a free graft onto the defect. And then again, you let this heal for about 6 months. And 6 months later, after the neourethra, the new urethral plate is well vascularized and matured, you tunnel it up to form a neourethra. So as far as grafts, people have tried bladder mucosal grafts, people have tried intestines, people have tried buccal. It's primarily used when a lung defect is present with without an adequate donor skin site. It's been used with babies with scrotal or perineal hypospadias as a single stage procedure. It can also be used a lot of times if you're doing a redo or if patients have had a prior circumcision. The second layer of neourethra, one thing that's been shown to really decrease fistula formation is flaps. So dartos flaps, tunica vaginalis flaps, and corpus spongiosum flaps. Here we can see a tunica flap. You essentially deliver the testicle, you take a piece of tunica, and then you swing it over to further buttress the neourethra, as well as a dartos flap, where you leave it on the pedicle, swing it over, and then add it on top for additional coverage. Buccal mucosa has easy accessibility. It has high resistance to infection. It's more compatible with the neourethra environment. It's also hairless, which is something to consider if we're considering buccal mucosa graft. It has a natural plane between the mucosa and the buccinator muscle. It should be defatted with removal of fibrovascular tissue, and for oral hemostasis, closed primarily if possible. The neovascularization between the graft and recipient site occurs between 2 to 4 days. It has a thicker epithelium and thinner lamina propria than bladder mucosa or penile skin. However, bad things can happen. There's lots of important structures in the mouth, and you can definitely have complications and side effects from a vascular standpoint, from a duct standpoint. Also, you have the facial nerve, you have and lots of muscle innervation. So it's not as simple as just getting a buccal. Sometimes these things can happen. Yes. Huh? Okay. So complications from hypospadias is directly related to the complexity of repair and is generally about less than 2% with meatal advancement and glanoplasty. Most of the side effects there is just bleeding and hematoma. It's 5 to 10% with meatal-based flaps and up to 6 to 30% with the more extensive perineal reconstructions. Long-term outcomes it's also been described 30 to 50% with proximal hypospadias, and most require multiple surgery. Meatal stenosis, fistula, and stricture can present years later, and also pubertal growth when the penis starts to significantly grow more can also affect the outcomes. Hypospadias patients also report more urinary symptoms and are less satisfied with penile appearance compared to controls, and up to 30% report persistent curvature, as well as lower urinary tract symptoms. So as you can see, this is a normal bell-shaped curve, and this is a curve that's been described with patients that have had a prior hypospadias repair. So looking at all the literature, when you talk about comparing one stage versus two stage complication rates, it varies according to institution, and then the consensus is that it's up to surgeon preference as well as the severity and the location of the hypospadias. So there's no clear guidelines about which pathway to choose. So going back to our patient that we saw with the severe hypospadias, and here's another one Dr. Arlen and I did back in January. This was creating the neourethra. We used a ducket tube, and this is the outcome. We did this in one stage. So one thing that I think is important right now, and this is an issue that Dr. Hiddleman has really been tackling, is that there have been legislation that have been passed, or not passed, but have been proposed in different states and now in Connecticut. So right now, a hot topic is gender assignment surgery, intersex surgery. And one issue that's been really pushed is they're trying to lump hypospadias into essentially intersex surgery, which we know as urologists that hypospadias surgery does not determine gender outcome. You know, these are XY males, and these are patients that this is an issue that at birth it's due to congenital malformation. So one thing that they're trying to propose is that any of these surgeries should be reserved until patients are of the age to essentially give assent, which would be, you know, anywhere from like 12 to 13 years old. And I think that would be really tough if I had a child that had perineal hypospadias and I was told that I can't have surgery here in the state of Connecticut and we had to travel elsewhere. We have the means to do that, but I think that'd be very challenging for a lot of patients. I'd like to ask Dr. Hiddleman to kind of speak on the efforts that have been, just kind of briefly touch base on the efforts that have been going on.
Yeah. So obviously I think it's a difficult and controversial topic. The legislation that they proposed in Connecticut has aspects of it that I think a lot of us would support. I think the thing that mainly was our concern was that they were trying to prohibit surgery on any intersex patient, which meant that they really lumped together a very kind of wide pool of patients into a single diagnosis. Here, they didn't include hypospadias, and if you ask the authors of the bill if they were planning to, they would say they didn't. But that same statement was made in California, Nevada when they proposed their initial bills, and now they are trying to expand it to hypospadias. And I think some of it is just a lack of understanding the nuance of the argument. And partially, I think it's a little bit of insincerity. So by bringing in hypospadias into this pool of patients, mainly it just increases the N. So you can say it's really affecting a large population of people, and hypospadias would be the largest volume. They could then say that it really has a bigger impact, which is why I think they're including it. The main group I think that's really affects is kids with congenital adrenal hyperplasia, and whether or not you would do surgery to correct their urogenital sinus, the common urethra and vagina, versus doing a combined surgery where you'd reduce the clitoris. So they would argue that the movement of the urethra would not be included in surgery, but the clitoroplasty would. So again, I think you start getting to the nuanced arguments of what is allowed and what is really the goal of our surgeries. And I think people kind of cringe when we say we want to normalize genitalia or normalize appearance, because it has this argument that maybe they were abnormal in the first place. And I think people, as they make this kind of general conversation, are moving away from this binary or dichotomous gender. And as you can see in the third item of this bill is to try to allow for this not to be such a dichotomous thing, that they want there to be IDs or legal aspects that allow a non-binary gender. So it's really a very complicated issue. The bill that they proposed here made it sound very simple. And to be sincere, a lot of very, prominent liberal groups have signed on to this: ACLU, Planned Parenthood, Amnesty International. So if you use terminology like gender mutilation or things that sound horrible, or why not just wait until someone can decide themselves, it makes it sound like a simple idea. Sure, let's just wait till the kids are older and they can decide if they want to be boys or girls. And to be honest, that's really not an issue for the majority of them. And the largest pool, like I said, the congenital adrenal hyperplasia population, their support group, CARES, actually doesn't consider themselves to be intersex. They just consider themselves to have girls, daughters with an adrenal gland problem. So the majority of patients that this really affects don't even see themselves as part of the pool. So it's a complicated question. Toby, man in the front.
So this was brought up in the AUA. This bill going around all the different state houses brought up at the AUA Advocacy Summit that I attended last week. Lane Palmer is the pediatric urologist who's been sort of spearheading the fight against these legislation. And the way this all came about, it's obviously very political. It really was not well researched when the bill came out, and you commented like the legislator said, well, we didn't think about hypospadias. And what had happened was, have you guys heard of, I think it's called Human Rights Watch, or some group? There's a one that's on one side, and they got actually medical students also supporting this bill without doing research. It went to the AMA, and the AMA actually did a great job in terms of doing research, presenting data, coming up and working with CARES, or is it CARE or CARES, that group with whatever that, so the congenital adrenal hyperplasia support group is working with a pediatric urologist to basically fight against this bill. Anyways, I sent a letter against this bill to the state legislature. I think you all got that in your email that Dr. Hiddleman sent. I hope those who had time, took the effort to do that, because I think it's really important.
The bill sponsored here was by a local legislator and co-sponsored by a state senator, Lesser. And I agree with what Toby said. So the bill that was proposed to the AMA came through AMSA, the Medical Student Association, and again with good intentions. And it wasn't so simple that the AMA just denounced it. I mean, they actually spent 2 years. They did a really deep dive into it. They addressed it from many levels, including ethical issues. And mainly what their argument at the end was really for parental rights and autonomy. But they didn't black and white say, hey, this is, a problem and we should be able to operate it whenever we want. They acknowledged some of the issues with it. I think they were pretty open about their concerns with doing surgery on some folks. And the medical community has a lot to play in this. We made a lot of mistakes in the past. And I think as a paternalistic society, we would say this is what we should do and this is how the surgery should go. And we've changed that a lot. And I think the problem is the bills are coming up now kind of in the political climate, which is very, diverse and, an opportunity to fight these things, but it doesn't acknowledge the changes in the evolution that the medical community has made. We've really changed a lot. So we've kind of addressed a lot of their concerns, but it's a very divisive issue. Yeah. So if you have complicated, very proximal hypospadias, if you have partial androgen insensitivity, where you have a lot of other issues that go with it, there was an advocate who spoke up at the state legislature a couple weeks ago when I went up there, who had many, many surgeries as a baby and ultimately developed urethral stricture. And his description was that they amputated his penis so he could pee. Now, most of us would recognize that. I'm sure that's not what happened. His interpretation is that's what's happened, but they do. They'll bring up some 60, 70-year-old gentleman who had really complicated surgery years and years ago, who's had a very difficult life and is unhappy. But it's hard to translate that to don't operate on a baby. And I think when I pushed that person, I spoke with him after, it wasn't really clear what he wanted. He was just unhappy. I think a lot of it's being unhappy. Some of the very strong advocates for this are folks who have complete androgen insensitivity, whose testicles were removed at a young age. So it limited their ability for the testicles to produce a lot of testosterone, which gets converted to estrogen. Then they would have secondary sex characteristics that develop. But ultimately, that it didn't. They're concerned about becoming infertile or sterilized, or some of the terminology they're using isn't really true because they're not fertile in the first place. It's just the complication of the story. They don't fully understand it, but they feel that they were operated on without their assent and their sense of not being whole. So it's a complicated problem. It's
hypospadias, in infancy versus later on in life and success rates. I know it's probably hard to answer because
yeah. So they've done studies on folks that have had it later in life, and clearly complication rates are higher and they're more difficult outcomes. Part of the problem is a lot of the arguments are really based on not necessarily on outcomes, surgical outcomes, because it's clearly more difficult to do surgery later, but it's on regret. And if you look at folks who had surgery as babies and they ask the parents later on, the regret rates are very high. It's like 40%. But if you had your child's tonsils removed, then regret is 40%. And if you had them fix cancer or address cancer, then the regret is 60%. So it depends on the context of the conversation. everyone has regret that their child needed surgery for all surgeries, including life-saving surgeries. So they're very difficult arguments.
All right, now for something completely different. All right, so we're going to talk about kidney stones and pregnancy. The reason I picked this topic is pretty controversial. I think it was pretty nerve-wracking for a lot of us whenever we get consulted for stones on pregnant patients. A couple patient scenarios. I have patient A. I'll talk about hydronephrosis in pregnancy, diagnosis of stones in pregnancy, treatment of stones in pregnancy, what are the risks and complications of treatment, and then we'll finish with a patient scenario. So the first patient I'm going to talk about, 31-year-old woman. She's G5. She's 38 weeks. She comes to the ED with sudden right upper quadrant pain, vomiting that began 2 days ago. She had an ultrasound in the ED that showed mild to moderate hydro. 12 hours later, she had another ultrasound that showed a new perinephric fluid with internal debris suggested of Achilles heel rupture. Neither ultrasound showed evidence of a renal or ureteral stone bilaterally. In terms of her physical exam findings, it was only notable for 13 RBCs in her UA, 12 whites, negative Lukes and negative nitrites. And she had 2 urine cultures that showed mixed flora during the submission. She's never had stones in the past. She has no familial history of stones, hypertension, depression, and asthma. She takes no medications. She's also had no surgeries in the past. So how common is hydronephrosis in pregnancy? So there are many articles that looked at 43 to 100% in all pregnant women, depending on their gestational age. When they did ultrasound measurements of the renal and pelvic calyceal size in pregnancy, it progressed. This size has been related to an increase in the vascular and interstitial volume. Why does it happen? It's thought to happen for 2 different reasons. Progesterone, which is increased during pregnancy, has shown to reduce ureteral peristalsis and increase pressures in the ureter, causing hydronephrosis. There's also thought to be a mechanical compression of the fetus due to the fact that the fetus is usually rotated on the right side at an acute angle and can press upon the right ureter. Patients with hydronephrosis present with flank pain, abdominal pain, pyelonephritis, and renal failure. Often they are asymptomatic, and as all of us know, this can mimic the same signs as kidney stones. Renal colic can be due to mechanical obstruction of the ureter, hematuria, and also can be secondary to a rupture of the pyramid veins due to renal enlargement. So returning to our case, we originally counseled this patient on conservative management. After having pain for 2 days, she had a normal spontaneous vaginal delivery. CT scan after the surgery, despite the Achilles heel rupture, showed no evidence of a radiopaque stone. There was also the patient denied any passage of stone. So what about those patients that actually have kidney stones? How common is it? Renal colic is the most common non-obstructive cause of hospitalization during pregnancy. However, the incidence of symptomatic stone disease is relatively low. The prevalence of stones does not increase significantly during pregnancy as there are opposing physiologic changes. Things that can cause stones, there's an increase in renal blood flow, GFR, urinary sodium, and calcium excretion, but there's an also increase in stone inhibitors, citrate, magnesium, and glycosaminoglycans. In terms of workup, it's the basic diagnostic workup that we already do. You should get a UA, you should look at the pH, you should look for whether or not the urine's acidic, get a urine culture. It's not recommended that patients that are pregnant get 24-hour urines at the time they're pregnant. In terms of diagnosis, ultrasound is considered the first line and best diagnostic tool for women that are pregnant. However, ultrasound, as many of us know, is dependent on the skill of the technician. It's dependent on the body habitus of the patient, whether or not they have bowel gas, and can sometimes be not very helpful. Multiple studies have showed the sensitivity ranges of ultrasound to be 28 to 86% for urinary calculi, and it can be very difficult to visualize the mid and distal ureter. Some studies have looked at the use of transvaginal ultrasound, which can be well tolerated in some patients to visualize the distal ureter. It's also important, if you can, to look at the ureteral jet, but due to body habit, it's not always possible in pregnant patients. And ureteral jets may be absent in 15% of asymptomatic pregnant women, so not also that helpful What about MRI? MRI does not require any ionizing radiation. There's the HASTE sequence, which can quickly visualize the upper urinary tract and locate obstruction without the use of IV contrast. Animal studies have shown that MRI dye does cross the placenta. However, in its chelated form does not cause any teratogenic effects. There have been a few studies where pregnant women have been subjected to gadolinium with no adverse effects. But however, because we do not know the safety profile, we recommend non-contrast MRIs. This is a picture here that demonstrates a pregnant woman who underwent a non-contrast MRI. You can see that there is a filling defect in the proximal ureter that was later correlated with a right ureteral stone. So what about CAT scans? CAT scans for non-pregnant women are considered, yep, sure. No contrast study. Correct, yep. So CAT scans are considered the gold standard for non-pregnant patients with a 99% sensitivity and specificity. However, as many of us know, there are risks of radiation to pregnant women. What are those risks? Fetal demise, malformations, growth retardation, and carcinogenic consequences. However, ionizing radiation, ionizing radiation, the reason this happens is because as we increase the radiation dose, there are deterministic and stochastic forces on the fetus that can cause this. But we don't really know at what threshold. We have an idea of what threshold that happens, but we're not always sure. But for the most part, this has only been shown depending on the gestational age of the fetus. Going back to 1977, there was a statement released by the National Council on Radiation Protection that said that there is a minimal to no risk for fetuses at a 50 milligray radiation dose, and that the radiation dose that results in the things that I presented before, for the most part, only happens at 150 milligray. Exposure to less than 50 milligray, according to ACOG, has not been associated with an increase in fetal abnormalities or pregnancy loss. So when we get a non-con CT, how much milligray are we delivering? Depending on the CT scan, it's about 15 to 25 milligray. For a large patient, it may be higher. So if 50 is the cutoff and 15 is about what the normal non-con dose of radiation that we're giving, you're probably wondering, how can we even further decrease the dose of radiation that we're giving to patients? Is there anyone we know that studied this in the past? No. So there was a study that was published in the recent past that looked at low-dose CT scans by Dr. Singh. And in this study, they looked at regular and reduced CT scans in 201 patients, 63% receiving the high dose, high BMI reduced dose. They found that sensitivity of the reduced CT for ureteral stones greater than 5 millimeters was 100%. And they were able to reduce the radiation given to patients from 21.7 to 3.4, which is a reduction in 18.6 milligray. Going back to my previous slide, the low-dose CT, depending on your institution, is about 3 to 12 milligray, which is below the threshold for 50. However, CT should not be considered first-line diagnostic test. I'm just stating really what the recommendation with the radiation is. So with that being said, you're probably wondering, what does ACOG think? What does the American College of Radiology think? What do the other professional societies think? In a consensus opinion that was released in 2017, the ACOG, American College of Radiology, and the American Institute of Ultrasound came out with a statement that reflects emerging clinical and scientific advances on this topic. The reasons that the authors released a statement is because imaging studies are important in the diagnostic evaluation of patients. However, there is significant confusion about the safety and modalities for pregnant women and lactating women. So what are the recommendations of these three societies? They say that ultrasound and MRI are not associated with an increased risk and are the test of choice for pregnant patients. With few exceptions, and I don't get into those exceptions, but they're talking about full dose CT scans for PET scans, X-rays and CTs, as well as nuclear imaging, are given at doses much lower than exposure associated with fetal harm. If these techniques are necessary, in addition to ultrasound, or more readily available, they should not be withheld from pregnant women. When talking about gadolinium contrast, they say that it should be limited in the use of MRI. It may be used as a contrast agent in pregnant women only if it will improve diagnostic performance. And for breastfeeding patients, it should not, gadolinium should not interrupt breastfeeding. This is a chart that was released in the same recommendation that looked at what we had just talked about just now, that looked at the dose of radiation to the fetus for abdominal and pelvic, which is about 1.3 to 35, depending on the CT scan. So what does the AUA say about CT scans in pregnant women? In a statement that was released by some of the leading authors in the field of endourology, they talked about ultrasound as the initial modality of choice in pregnant women. However, if the diagnosis is not established, the study during the first trimester, an MRI should be considered. And for second and third trimester patients, they are candidates for low-dose CT scans if the ultrasound is not diagnostic. So you're probably saying, all right, well, we got the ultra-low-dose CT scan. Now we know they have a stone. What about the risks of doing surgery? What about the risks of anesthesia? What are those risks? So we'll talk a little bit about treatment of ultrasound or of stones. So early studies had recommended conservative management for the expectant mother. Watchful treatment has historically been successful from 65 to 85% of cases. However, in some recent studies, they feel that this data is flawed owing to erroneous diagnosis, incomplete follow-up, and there may be bias as some surgeons are unwilling to operate on pregnant patients. But what type of conservative management is safe? Is Flomax safe? Or pain prescription safe? What can we give to patients? So opiates are considered first-line therapy. We can also give Tylenol, but it is not recommended that we give NSAIDs or aspirin. Going back to ACOG, ACOG states that opiate use during pregnancy, including methadone, can put infants at risk for neonatal abstinence syndrome. However, this does not lead to long-term consequences. So you can give opiates to pregnant women. And it also states that opiates may be needed to treat a chronic and acute pain, including kidney stones, as a part of an established plan to treat problems associated with substance use disorders. What about Flomax? Flomax is considered a Category B medication. And for those of you that can't remember the FDA categories, that means that animal reproduction studies have failed to demonstrate a risk to the fetus. There are no adequate and well-controlled studies in pregnant women. There was an article published in the Journal of Urology that looked at Flomax therapy in symptomatic pregnant women. They retrospectively identified patients from 2000 to 2014, 27 patients that were pregnant. They looked at what trimester they were in, how long they got Flomax for, and they found that when they compared medical expulsive therapy to control groups, there was no significant difference in maternal or infant outcomes. A large percent of the pregnant women with symptomatic stones also harbor infections. So as you probably realize, it's important to think about antibiotic use. Cephalosporins, penicillins, macrolides, nitrofurantoin are considered to be safe. Get a urine culture to help use their micro.
How many babies are delivered at Mayo Clinic? I was shocked that it was a Mayo Clinic delivery.
Not sure.
It's not a destination spot to deliver babies. Rochester, Minnesota.
I'm sure they have local deliveries though. So what about shockwave? Shockwave is considered to be contraindicated in pregnancy. It's one of the most important contraindications. There are reports of shockwaves being performed in pregnant women accidentally. However, for this reason, it is not an indication for termination in early pregnancy, but it cannot be recommended as a practical treatment. What about stents? We commonly ask patients to get stents. Stent placements can be performed in a retrograde fashion. We can do it under regional or general anesthesia. We can do it with fluoroscopy. Typically, we do it here with ultrasound. The biggest risk for ureteral stents is incrustation, and it's recommended that, depending on what article you read, that you get an ultrasound every 4 to 6 weeks and consider changing the stent due to this risk of incrustation. Patients can also get a nephrostomy tube, which just allows for immediate decompression of the kidney. Sometimes can be done under local sedation. Conversely, the problems with nephrostomy tubes is there can be increased bleeding, discomfort. It can be annoying for pregnant women to have a tube outside their body. There's a possibility of the tube getting dislodged, and there's also a chance that the tube gets encrusted. What about ureteroscopy? Ureteroscopy is now, according to articles, becoming more common option for treating stone disease in pregnant patients, specifically when they're in their second trimester, as I'll go on to later. Modern ureteroscopies allow for easy access to the upper urinary tract, and ultrasound can be considered feasible during this to avoid using fluoroscopy. If fluoroscopy is used, you should use a pelvic lead shielding and culmination of the image. Stone-free rates are 70 and 100% after ureteroscopy. It's recommended that we use a holmium YAG laser during this, which I believe we already use. It's recommended that these patients get stents afterwards. We don't recommend stentless ureteroscopy, as it's considered to be so much more complicated. Have stents in place for 3 to 7 days. And when ureteroscopy was performed in a large retrospective trial that I'll talk about later, a majority of patients did get stents, it was about 68.9%. One of the authors from Johns Hopkins University published a review in Nature on the topic of pregnancy and kidney stones. And the authors outlined a similar flow diagram to what I talked about to get a renal ultrasound. If there's no stones and you're unsure, you can consider MRI or MRU haste without contrast or low-dose CT. For patients with stones, depending on whether it's a complicated or uncomplicated case, you can offer surgery, which can include ureteroscopy versus stent or nephrostomy tube. So what are the risks and complications of this? You know, we're talking about ureteroscopy, but one of the, I think, biggest risks a lot of us are concerns we have is preterm labor. How common is preterm labor? What about UTIs? So the treatment risks have to do with the length of the procedure, hospital stay. There's also, they looked at ureteroscopic complications, but there was no difference in a study in 2014 between pregnant women and controls. Obstetric complications are rare, but in 2 to 4% of patients, premature uterine contractions can occur. And this is more common in women that are in their 3rd trimester. Maternal and fetal deaths have not been reported in the literature, but fetal viability can be assessed preoperatively and postoperatively with ultrasound or fetal heart rate monitoring. So you're thinking about, well, you know, I want to put this person under anesthesia. What does ACOG think about it? What do the anesthesiologists think about it? In a statement released by ACOG in association with the American Society of Anesthesiologists, they state that there is no currently used anesthetic agent that has been shown to have a teratogenic effect in humans using standard concentrations at any gestational age. Fetal heart rate monitoring may assist in maternal positioning and cardiorespiratory management and may influence decision-making to deliver the fetus. They also say the following recommendations: a pregnant woman should never be denied an indicated surgery. Elective surgery should be postponed to after delivery. If possible, non-urgent surgery should be performed in the 2nd trimester, and the reason for that is to reduce the possibility of preterm labor. I was also kind of curious about general anesthesia versus epidural, regional, local, or epidural anesthesia. There's never been a study that shows that epidurals are more superior over general anesthesia when operating on patients when they're pregnant. When I spoke to our own anesthesia department about this, they said that they have a preference towards epidurals, but they also acknowledged that there's never been a study that's looked at this conclusively. And a study out of Johns Hopkins that looked at the safety of ureteroscopy during pregnancy in a meta-analysis. They identified 108 patients from 14 different reports. They included complications of UTI, post-op pain, ureteral perforation, and premature contractions in 1 patient. They said when compared again to ureteroscopy in non-pregnant women, there was no significant difference in the rate of complications. These are 14 studies that had 108 total patients. In a multi-institutional study, and these are the institutions, they looked at 45 patients at these 5 institutions, and I also reached out to some of the residents I know at these institutions to talk about what their practices are. 2 women underwent ureteroscopy during the first trimester, 24 in their second, and 20 in their third. Of the 46 procedures, 50% of patients had a low-dose CT scan prior to surgery. 39% had ultrasound, and 5 had MRI. A majority of these patients underwent general anesthesia. In terms of intraoperative imaging, 83% had fluoroscopy, 17% had ultrasound. In 7 of these patients, 15% of the patients, no stone was identified. Many underwent lithotripsy, basket stone extraction, and 96% underwent stent placement. So what about the patients that underwent negative ureteroscopy? What kind of studies did they have prior to surgery? 1 patient had a low-dose CT, 5 had ultrasound, and 1 had MRI. But what about the obstetrical complications? What did the authors say about that? So the authors go into some detail on this topic, but they talk about 2 patients. The first one was a 30-year-old woman that underwent ureteroscopy at 33 weeks gestation. She had an ultrasound suggesting a single ureteral stone. However, intraoperatively, the patient was found to have a significantly larger stone burden that could not be identified in ultrasound. She had the longest surgery in the course, 109 minutes, which was performed with an epidural. In the PACU, the patient went into preterm labor, and she had a C-section. There were no apparent long-term consequences of preterm delivery. The second complication was a 29-year-old woman who they performed surgery on at 30 weeks. It was only a 13-minute surgery, ureteroscopy and basket stone extraction. This patient also went into preterm labor afterwards. And however, she was conservatively managed with tocolytic therapy, and she went on to carry her pregnancy to term. So now we're going to talk about one more case, and we'll see what the audience thinks about what they think they do in these situations based on the data that I presented today. So this is a 24-year-old woman. She's G3P1011 at 40 weeks and 4 days. She developed sudden onset right flank pain yesterday morning with associated nausea, vomiting. She had an ultrasound showing mild to moderate hydro with no evidence of a stone. Creatinine's normal, white count's normal. UA is negative, 5 white blood cells, 42 RBCs, few bacteria. She had a urine culture that showed less than 10,000 organisms. She states that she has had stones in the past. However, she states that they resolve spontaneously and she passed them. She takes no medication. So based on this information, you're seeing this patient for the first time. What do you guys think you'd do? How many people here would recommend conservative management? Majority. Anyone get a low dose CT scan? Yeah. Anyone else do anything else? She's almost 41 weeks. I agree. So the OB team actually got an MRI without IV contrast, without talking to us, and it showed moderate hydronephrosis, secondary compression, no evidence of filling defects, no evidence of a ureteral stone. She was consented to undergo induction. She started an oxytocin drip. She had an epidural place, and she received 91 milligrams of IV morphine during this time. Hospital day 5, the patient developed a fever to 101. She was started on clindamycin and later megamycin, gentamicin. However, she was persistently febrile to 101, now with tachycardia and new onset hypotension. There. So now she's being induced, and now she's spiking fevers. What do you guys think you'd do here? We don't know there's a stone. We got an ultrasound and MRI that showed no stone. Yeah, so we spoke with the OBs. She said that there was no chance that it could be amniotis, that they had no concern that this was obstructive in nature. UA and urine culture were negative. So what do you guys think you do here? C-section. C-section? Okay. You can call Dr. Shulam if you're not sure. All right. So for those of you who want to get a CT scan to see if there's a stone, we couldn't because the patient was in an oxytocin drip. She later underwent a C-section. She was persistently febrile to 101. Oh, I'm just saying I mean, you could consider it if you're concerned there's a stone. Who cares? Yeah.
I think one of the driving forces in all the recommendations are, what is your intended management based on the information obtained?
Yeah.
So if you get a CT scan and the patient has hydronephrosis of pregnancy
Right.
without a stone, and she's febrile, let's say she wasn't this close to delivering, you
Yeah.
would probably decompress her that she's febrile. You think she has the urinary source, so you perk her or something like that. If she has a stone and she's this far in her pregnancy, you would probably perk her.
Uh-huh.
So if you think that she has hydro, she's obstructed and febrile from a urinary source, you're either going to go ahead with induced labor, C-section, or decompression of the kidney and relief of the point of obstruction with the fever. You are never going to manage the stone.
Okay, but I guess the question is, would anyone here consider an intervention at the time of the C-section if they knew there was a stone? No, no one would consider that. We weren't considering it, but I was just kind of curious to see if anyone felt differently about the way we managed it.
I guess if your question is, does this patient have an obstructing stone
Yeah.
with a fever?
Yeah.
And just like if she would present to the ER like this,
Yeah.
that's a different situation.
Bruce, can I just ask a question? So you're saying, like, say earlier, not this situation, but a little bit earlier, even if there's no stone, she's obstructed potentially with a fever, with all that. So you're sort of going to treat it like a stone, like an obstruction, even though it's not a stone. You're still going to.
What about after delivery?
I'm talking about like say she's 30 weeks.
All right.
Patient A that he presented did not have a stone and
Right.
the calyceal rupture. So obviously, hydronephrosis pregnancy or obstruction of the gravid uterus is obstruction, just like a stone.
Right.
So if you have obstruction with a septic-like picture or a febrile,
To decompress.
I think decompression
Yep.
it's a low-risk intervention.
Right.
That's what you're getting it off the table. I don't know. Is there a
Post-operatively, she was bleeding from her C-section to the point where she was hypotensive again, with persistent fever. She was not able to leave the floor for any procedure. After 6 hours, we were able to get a non-con CT that showed a 5 millimeter obstructing stone in the right proximal ureter, and we took her for an emergent right ureteral stent. And then the patient was discharged 2 days later. Yeah, sure.
Curious. Two questions. One is,
What are you going to put on your surgical consent form? Because it's obviously there's a lot of risk. So I want to know what you're going to actually write down that's unique from other surgeries. And then the other question is, do we have any policy here on who needs to be in the OR at the time of doing surgery on a pregnant person? Does there have to be some sort of fetal monitoring? Is OB involved during those cases?
Yeah, so I didn't want to clutter my slides, but the ACOG does have recommendations on what's appropriate in terms, it depends on trimester. So early non-viable fetuses in first trimester, you need to get fetal heart rate monitoring pre and post surgery. If the fetus is considered to be viable second or third trimester, you need to get fetal heart rate monitoring intraoperatively with availability of an OB. So I'd probably put risk of preterm labor, fetal demise, risk of harm to the mother, and possibility of teratogenic effects of the fetus. And those are all things. Actually, this lecture was supposed to be given in conjunction with the postmortem sperm extraction. I spoke to the legal department about whether or not they've ever had this issue in the past in terms of operating on pregnant women and CT scans. Said no, as far as I know, they never had a lawsuit involving this. And as you said, what the most important part of this, whenever we consider getting a CT scan or operating on pregnant women, it's an informed consent and discussion with the patient that's well documented in the chart.
the ones that we've done here, the OB team are really good about being present. They have a nurse. If the fetus is viable, they have a nurse monitoring. The obstetrician comes and discusses all the risks of preterm labor, C-section, things like essentially consents the patient for that going into the OR. They're on hand available. If it's non-viable, they're just confirming that there's a heartbeat beforehand and confirming after. Because if they do undergo preterm labor, it's non-viable. There's no indication.
Yeah, I think OB has been very good here. I was going to ask on your studies about those multi-institutional pregnancy studies, did they have intraoperative fetal monitoring?
A majority, in conjunction and coordination with what I just talked about, it's depending on second or third trimester, there was OB presence usually for those cases.
Yeah, they're very good here. Don't put up a fuss at all. They're there right away. They do a very good job. Just a quick comment for the group to know, not that I'm recommending CT scans in pregnant women, even though it may be safe, but now we're down to 2 milligray on normal non-obese patients. That's how ultra low dose or low dose is. And the second thing is you presented MRI with a nice picture and you see a stone.
Never really looks like that.
And yeah, I mean, and Alex asked the question about how do you see it. So remember T2, like H2O appears bright, so it mimics a urogram, right? Because water looks bright. But we've all had patients who have had cancers and have had stones. Majority of the time, I would say, well, more than 50% of the time, you do not see the stone on the MRI. We've had CT scans. I mean, cancer patients are followed with and without contrast studies. Don't see them. So I think an MRI can be done, but I'm surprised they even put it on those recommendations because if more than 50% of the time you're going to make a conclusion that may not be accurate, why are they even recommending that study?
Yeah, I mean, we got an MRI in the patient that I last presented and said no stone, and then she had a stone. I mean, it was essentially exactly what happened. All right, so quickly, summary: ultrasound, first-line diagnostic test. You can consider low dose in second and third trimester patients. X-ray and CT are administered depending on the dosage at a dose much lower than exposure associated with fetal harm. You can consider Flomax, Tylenol, and opiates. Ureteral stent and nephrostomy tubes can be considered for pain. Ureteroscopy provides definitive treatment for some patients. Anesthesia has not been shown to be harmful to the mother or the fetus, and there is no benefit to regional over general anesthesia.